welcome everyone again. We have a great session today, and we will be going over the ASH annual 2023 conference updates on rare hematological disorders. So we have myself that I will be going over the VAX's syndrome and PNH, some of the updates, and then Dr. Shen will go over the hemostasis and thrombosis, and Dr. Ibrahim will go over the TTP and sickle cell disease, especially the gene therapy. So we have a lot of stuff to cover today. So this is the study that was presented by NIH guru Dr. Patel. Basically, the VAX syndrome, just to give you a background, is a vacuolization on the hematopoietic stem cell, E1 enzyme, the ubiquination enzyme deficiency with X-linked disorder, with autoinflammation and somatic UBA1 mutation. So that is some sort of described back in 2019 or 2020. It's a refractory adult onset autoinflammatory syndrome, and that ubiquination defect lead to a reduced protein degradation and activation of autoimmune pathways. Most of the time, these people will be very refractory to conventional treatment. They reported 44 VAX's patients. There was a different variants of the UBA1 mutation, and at the time they presented to the NIH for VAX syndrome, disease enrollment, they had a median of 6 years before they presented to NIH. So it's some sort of late diagnosis for this newly defined disease, and most of them happened to be on the prednisone when they presented to the NIH. And they, as you can see on this figure, that most of them had no hematological phenotype when they presented in initial phase, right? They had more of the rheumatological disorders, and then when they presented NIH, they had more of a hematological issues. But they initial presentation for them was the rheumatological issues, and 20% had died during this period of follow-up. As you can see, is a pretty high mortality disease. 14% had the transplant, and 9 were proceeding with the transplant. So as you can imagine, it's a very refractory disease that most of the time require transplant because of the 50% of them will have the MDS. So this is another slide, another presentation from the Italy group, Dr. Grunari. They presented the VAX syndrome refractory to conventional treatment, how they salvaged with the allo transplant. It was an experience from the EBMT group. They had only 13 patients with the median age of 58. Most of them, you can see that had the MDS disorder. And then they had the median of 46 months from the VAX's diagnosis onset, and before transplant they were treated with the various rheumatological disorders, including some of the hematological treatment with azacitidine and ruxolitinib. And you can see here 92% of the patient achieved a full donor chimerism at last follow-up. Acute GVHD happened in 1/4 of the patients, but there was not much chronic GVHD in the follow-up of that 2 years. And you can see here the 2-year OS was 80% with this refractory VAX's patients. So I think I will change a little bit gear here and talk about PNH and complement. In general, I think it's important to understand complement pathway to understand the PNH treatment. There has been many evolving treatments for PNH in the last 20 years, started with the C5 inhibitors, you can see on the screen. So this kind of slide is important to understand there is a different pathways, inhibitors or activators. So up until C5, we named them proximal pathways. Below that is called terminal pathway. Why is it important? It is important because there are medication that is targeting the proximal pathways, and there are medication targeting the terminal pathways for the complement inhibition. So I want to introduce 2 new entity or kind of go over it just to firm in your mind what does it mean. So when it comes to treatment with complement inhibitor, there is two possible consequences of complement inhibition. The number one is extravascular hemolysis that may happen when you are inhibiting the C5, that will back up to the C3, and the C3 will be opsonizing your red cells, and that will lead to extravascular hemolysis. This is mainly a problem of C5 inhibitors. Why? Because the terminal pathway will be inhibited. And we can see this up to 20% clinically significant extravascular hemolysis. The patient will be placed on inhibitor, will drop the hemoglobin. The LDH will not rise to the level that we see in the intravascular disease, right? Intravascular will give you the LDH of thousands, but with this extravascular, LDH will be around 400, 500, but you will have a significant anemia. So again, this is a problem of the terminal pathway inhibitors. Whereas the breakthrough hemolysis is another entity. When you block the proximal pathways, right, you are not inhibiting the terminal pathways. That can lead to activation of C5, right? And that can lead to a breakthrough hemolysis. This is unpredictable kind of side effects of proximal pathway inhibitors. And you have to be very vigilant, because patient can drop the hemoglobin from 10 to acutely drop to 4, with LDH will rise up to thousands, because this is an intravascular hemolysis, breakthrough hemolysis. So with saying that, these are the ASH 2023 updates on the different complement inhibitors on PNH. As you can see, there has been in many studies from phase 1 to phase 3. So I will only go over the 2-3 studies that was reported at ASH, especially the phase 3 trials that is led to some of the approvals. So this is the oral factor B inhibitor, iptacopan. So this was the extension period kind of report that reported the 48 weeks data from the treatment naive PNH patient that was enrolled to iptacopan, and also the patient who switched from the C5 treatment to oral iptacopan therapy. That was presented by, I think, Antonio. So, Dr. Risattino. So that the overall characteristics was equally distributed between the arms. The most of the people have had, extravascular hemolysis, as you can see here from the baseline LDH values. So, and the hemoglobin increased to 12 grams per deciliter at 48 weeks. This is a very good response. And when they switched from the C5 inhibitor to iptacopan, the factor B inhibitor, most of them kind of gained the hemoglobin response. So it decreased the retic count. The LDH, as you can see, happened to be in the range of 400, 500. So most of the people that was enrolled to this trial happened to have extravascular hemolysis. And you can see the LDH not much changed during the treatment period. There was some spikes here that kind of made the patient to have the breakthrough hemolysis that we will go over in a momentarily. And then the retic count decreased significantly when they were treated with the oral factor B inhibitor, and after they switched from C5, anti-C5 to oral B inhibitors. And so the most patients avoided transfusions, as you can see here. 90% of the people by week 48 was transfusion independent. And when they compared with the C5 arm, they happened to have more transfusion necessity, because, as I said, most of them happened to have the extravascular hemolysis. And the breakthrough hemolysis happened in 8% of their whole population, which is a little bit surprised, because when they presented at 24 weeks data, it was much less. And when they presented the 48 weeks data, it was a little bit higher than what we projected, what we kind of expected. So I think this is the patient profiles, how they kind of outlined each patient who had the breakthrough hemolysis. As you can see here, there has been some patients that dropped hemoglobin from 11 to 5, from the 10 to 7, from 13 to 4. So again, you have to be vigilant when you are using the proximal pathway inhibitors, in case they will have complement activation condition like infection, pregnancy, or some sort of COVID infection that can lead to activation of C5 further activation, so that can lead to a breakthrough hemolysis. And so you have to be kind of alerted with this possible side effects. So as a conclusion, they said it's based on this phase 3 trial, anti-C5, I'm sorry, the iptacopan arm as well as the anti-C5 to iptacopan arm had the rapid improvements, increased hemoglobin, decreased the transfusion necessity, and they also reported as a well-tolerated, no new safety data, but there was some BTH, the breakthrough hemolysis, among the people who were treated with the proximal inhibitor. So with that, I will move to danicopan. This is a trial that we were also involved. That was a factor D inhibitor that was used as an add-on, because as we went over, some of the C5 treated patients will have the extravascular hemolysis, and they aim to target these people who are transfusion dependent, despite that they are being on the maximum dose of factor 5 inhibitor. So I will go over it. You can see on the screen the 48 weeks data. You can see the placebo arm when they switched to danicopan, there has been a substantial increase in their hemoglobin levels. It's not as much as the factor B inhibitors, but there was a significant increase in their hemoglobin level. And you can see the retic count control happened when they switched to, when they added the danicopan in addition to C5 inhibitor. And also you can see here 90% of the people happened to be a transfusion independent by week 24, and they reported as an danicopan add-on to C5 inhibitor significantly improved the hemoglobin and controlled the retic count, as also kind of reduced the need for transfusion by addressing the clinically significant extravascular hemolysis, and there was no concerning infection with this adding the factor B inhibitor. This is another safety data for another C5 inhibitor, crovalimab. It's a sub-Q after the IV load. As you can see here, they presented the 3 different trials safety data for not to be concerned for any infectious, and not to be concerned from any complication from these trials. And you can see here, there was no significant differences when they compared with the C5 inhibitors. The only thing that was kind of interesting that kind of shown was 18% of them, I have to pull that up, but 18% of them had some sort of hypersensitivity problems for some reason. So that was the only kind of major kind of side effect that they reported when they compared with the C5 inhibitors. So kind of going over how many FDA approved complement inhibitors we have at the moment. We have 4: eculizumab, ravulizumab, pegcetacoplan, and iptacopan. Most of them will require some vaccinations, especially the proximal inhibitors recommended to get more the streptococcus as well as Haemophilus influenza vaccinations. And please remember to re-administer the meningococcal vaccinations as outlined here, as well as pneumococcal vaccine for the proximal inhibitors. So that's pretty much it from my side, and I will ask Dr. Shen to reflect his screen.
Okay, so I'm going to go over some studies on thrombosis and hemostasis, mostly on bleeding disorders. So the first one is one of the gene therapy trials. So this is a study that got the factor IX gene therapy approved by the FDA. They reported 3-year follow-up results. So there's a lead-in period, and then there's 3 years of follow-up. So in these hemophilia studies, the main endpoint that you're going to see is what's called the annualized bleeding rate, ABR, as well as total bleeds, and other basically different ways of quantifying the number of bleeding. But the ABR, annualized bleeding rate, will be the main one that most people pay attention to. So there's a lead-in period before the gene transfer, and then 3 years of follow-up. So you could see that before the gene transfer, the annualized bleeding rate was 4.17, and that decreased to 1.52. And correspondingly, you see a nice decrease in the number of total bleeds over time as well. And then the median bleeds per participant actually went from 2 to 0 in the follow-up period. And what's different on the factor IX gene therapy trials compared to the factor VIII gene therapy trials is that the factor IX activity tends to hold up over time, while the factor VIII level tends to decrease over time. So this is a factor IX gene therapy trial. So you can see that the factor IX level is holding up in the high 30s. There's a little bit of a drop from after year one, from 41.5 to 36.7, but then it came back up to 38.6. So the HOPE-B trial is using the factor IX PADOA gene. So that's the main reason why they're able to achieve such high factor IX levels. So this is the St. Jude study, and you may remember the St. Jude factor IX gene therapy trial was the first one that was reported to be successful in hemophilia. And so we were fortunate to put 2 patients on this trial early on. And so this is the presentation of the 10-year follow-up of that study. So the median follow-up was 10.7 years. There were 11 treatment-related adverse events in 10 participants. 4 out of the 6 that got the high vector dose had transient elevation of liver transaminases in the first 3 months, and none of them had recurrences after that. There were 2 new serious adverse events. There was a non-mucinous lung adenocarcinoma in situ that was not related to gene therapy. So what they did was they biopsied the lesion and looked for the viral vector in the tumor, and they did not find any. There was another patient with a prostate cancer that happened 12 years after gene therapy. And I do not believe this one was thought to be related to gene therapy as well. And overall, there were no inhibitors, no thrombotic events, and there were no persistent transaminitis or death. And so these were the factor IX levels. The different colors refer to the different vector doses. The blue color referring to the high vector dose. So they are the ones who achieve the higher factor levels. But as you can see, compared to the previous study, this one only got factor IX levels up to about 5%. And that's because in this trial, the factor IX gene used was just a normal factor IX gene, not the PADOA mutant. And so, again, this is that the PADOA mutation is the main reason why they were able to achieve such higher levels with the other studies. Okay, so those are 2 gene therapy trials. So I'm going to move on to emicizumab. So this is a sort of the real world observation of patients on emicizumab. So Dr. Tarantino reported this. So we're on the initial trials, the Haven studies, we all saw that emicizumab use led to a decrease in bleeding, even compared to routine prophylaxis with factor infusions. And that was especially true for the inhibitor patients. And to some degree, the difference was smaller with the non-inhibitor patients. So this is the real world data, from a few different groups. But so what you can see on top is that overall, the, the, the reduction in ABR was not as profound as we thought it was. You can see on this forest plot here, this actually crosses 1, and numerically the mean seems to be a little below 0, but this is not this is not statistically significant difference. If you break it down to different age groups, the younger folks, the 3 to 6-year-olds, did almost have a statistically significant reduction in their ABR, the annualized bleeding rate. So it seems like the difference may be more pronounced in younger children, but not so much in the older patients. Okay, so keep that in mind.
Sorry, can I ask a question?
Sure.
The switch, post-switch, was that post-switch from factor prophylaxis? And was that for inhibitor patients or non-inhibitor patients?
This is overall.
All patients on Hemlibra.
Right.
Oh, okay.
Yeah.
Interesting.
Yeah, and the switch is from prior prophylaxis. Okay, so this is another gene therapy trial. This is for factor VIII. It's fairly early, just phase 1, 2. And the difference with this one is that it's using AAV6 instead of AAV5 that the BioMarin product is using. So let's see. Treatment-related adverse events were relatively few, and it's really all related to almost all related to transaminase elevations in the early phase of the gene therapy after the gene infusion. There were 2 tachycardia events, 1 hypotension 6 hours after infusion. So far, there were no inhibitors to factor VIII, no thrombotic events, and no liver masses. And here's the factor activity. And so initially, they were able to achieve essentially normal factor levels, but similar to the other factor VIII gene therapy trials, the factor VIII level does seem to decrease over time, compared to the initial level. So there's some decrement in the factor VIII activity. All right, so moving away from gene therapy. So this is, we've been looking at these non-factor VIII, non-factor replacement therapy. So emicizumab was the first one. There's a few other ones that are being intensely looked at. In particular, tissue factor pathway inhibitor inhibition has been coming along. So this BASIS study is looking at an antibody called marstacimab, and this is a once weekly injection, I think. And the study basically show that the earlier studies basically show that there was measurable efficacy and safety with long-term administration in both hemophilia A or B patients. And so this is the summary of the adverse events. Relatively few, basically well tolerated for the most part. And here's the ABR on the trials. So the OD is on demand. And OP is the observation phase. So the patients would go from on-demand therapy before they will go on the trial, and there's an observation period, and then they start the treatment with routine prophylaxis. And so you can see that the ABR does decrease with the marstacimab treatment, going from 38 to 3.18. And then for the that's for the on-demand patients. For folks who are getting prophylaxis, the ABR reduced from 7.85 to 5.08. And then and the ABR further reduced in the long-term extension study. Okay, so that's one anti-TFPI antibody. The other one is concizumab. This is the one that most people have heard about. So this is further along in the development. So again, this is this is another anti-TFPI antibody, and that is being studied in both hemophilia A and B patients with or without inhibitors. And so here's the main result. Let's see. Yeah, so this is looking at joint total the joints that bled. So this really just describing the baseline characteristics, what the target joints are. And so here's the number of patients and the ABR, the median and mean ABR, and then a number of episodes. And so these are just not the column on the left are patients without inhibitors. The column on the right are patients with inhibitors. And so you can see that they're able to achieve relatively low ABR with both inhibitor and non-inhibitor patients. So this does seem to be holding promise in terms of achieving hemostasis as well. So I thought I would show a couple of things about other hemophilia issues. So for example, this one is looking at hemophilia carriers. So, over the years, we've really not paid much attention to the carriers. But it turns out that they do bleed more than expected. They don't bleed as much as our hemophilia patients, but they actually have more bleeding than a healthy individual would have. And so this is basically a study to look at that. And the upshot, I know it's a busy table, and the upshot is that these women with who are hemophilia carriers are actually at increased risk for bleeding manifestations and joint-related symptoms, regardless of factor activity. When we assess their joint health by the hemophilia joint health score, the HJHS, they actually have poor joint health compared to non-carrier women. So these folks do bleed, and we do need to pay attention. And there's an effort to do mutation analyses and ultrasound studies in carrier folks now. Okay, so moving on to von Willebrand the disease. So as you know, there's been a sort of a somewhat of a controversy in terms of defining where type 1 von Willebrand disease starts in terms of factor level. Does it start at 50 and below, or does it start at 30 and below? In the older NIH diagnostic recommendations, it stated that the factor level should be less than 30 before we consider the diagnosis of von Willebrand disease. But the more updated guideline from a joint task force wanted us to use to consider patients with higher factor levels in 30 to 50% range if they have bleeding symptoms. And so this study is basically trying to look at these cohorts of folks who have low von Willebrand factor levels. The interesting thing is that they're these are two different cohorts, but they seem to show that these folks may actually be in the same spectrum as they age over time. So the LOVIC cohort is the low von Willebrand factor in Ireland cohort. And then the WIN, W-I-N cohort is the Willebrand in the Netherlands cohort. So LOVIC, those folks have factor levels between 30 and 50. And in the WIN cohort, they all had less than 30, 30 or less when they enter the registry or database. Some of them remain persistently less than 30. Some of them have partial correction as they age to 30 to 50. Others had their factor level normalized as they age to greater than 50. So those are the three different subgroups within the WIN cohort. Okay, so this is basically the summary graph. The pink or red refers to the LOVIC cohort, and the others refer to the WIN cohort. So visually you can see that the LOVIC cohort patients seem to be a subset of the WIN normalized cohort, meaning that the LOVIC patients were actually older when they entered the study, while the WIN patients were younger when they entered the study. And as they age and the factor levels change, the ones who increased the factor, the von Willebrand factor level, are very much similar to the folks who are in the LOVIC cohort. And they also looked at the von Willebrand factor production by looking at factor A2 von Willebrand factor antigen ratio, as well as von Willebrand clearance by looking at the propeptide and antigen ratio. And this is showing that, again, these LOVIC folks seems to be very much the same as the WIN normalized folks. And then if you look at the mutation on the right, the table on the right, looking at the VWF mutation prevalence, LOVIC had a prevalence of VWF mutation at 36.4. The WIN normalized patients was at 22.6. The WIN persistent patient was much higher at 93. And so there seems to be certainly different groups of patients that we're looking at. The folks who are in the higher range may actually be just discovered later. If we had seen them earlier, maybe their factor levels would have been lower into the less than 30% range. And as you all know, the bleeding manifestations vary quite a bit amongst von Willebrand patients. And so whether they come to medical attention or not really depends on how severe, how prominent their bleeding manifestations are. but we may actually be looking at the same group of patients who started low and then rose into the higher factor levels. Okay, so that's basically that. The same group looked at also decimal present responses in these two cohorts, and this is basically showing us that the response to DDAVP seems to be better in the older patients. And that may have something to do also with the higher, the increase in Volibin factor as we age. It's not a great increase, but I think it's about like a 10% per decade increase over time. So this may be part of that. Okay. So moving on to thrombosis, I have a couple minutes. Okay. So moving on to thrombosis. So this is looking at factor 12. So I've talked about how factor 12, inhibition of factor 12 and factor 11 could be targets for anticoagulation. That may not result in significant amounts of bleeding. So this is a study looking at the haploinsufficiency of factor 12 and see what they were, so these folks had decreased factor 12 levels, okay? And so it turns out that these folks are actually protected against VTE, at least according to the data here. So this, again, would lend credence to the idea that inhibition of factor 12 may be a reasonable way to go in terms of an anticoagulation strategy. And just to, I wanted to show this study here looking at the different inherited risk factors and thrombosis to emphasize the difference between arterial versus venous clots. So the top table is just looking at the odds ratio of having a thrombotic event. So factor V Leiden, heterozygotes, prothrombin gene mutation heterozygotes, and versus double heterozygotes. So the double heterozygotes are at higher risk for thrombosis. We know that, and this study confirms that. But they broke this down to VTE versus CVA versus myocardial infarctions and peripheral artery disease. And you can see that on the graph here, the arterial events were really not increased with any of these different categories, either prothrombin gene, factor V Leiden, heterozygous, homozygous, or double heterozygous. Okay, it's the VTE that's associated with these mutations. So anyway, I wanted to emphasize that there is a difference. These inherited, the common inherited risk factors are really not associated with a significant increase in arterial events. And this is a liquid biopsy study looking at cancer-associated VTE. And I don't think this is any surprise. So basically, the higher the amount of DNA seen in the patient's blood, the more likely they're going to have a clot. So the higher the amount of cancer tumor DNA is essentially circulating tumor DNA is essentially telling us that they're more likely to become metastatic, and we know that metastatic patients are more likely to have clots. Okay, I think I'm just going to stop here. This is a validation. They're trying to develop a prediction for VTE amongst lymphoma specific patients. It seems to be to validate. They had a cohort, a derivation cohort, and validated in different cohorts. Seems to work, but the paper, the presentation didn't really explain to us how they come up with the, how to calculate the risk score. But it's interesting that they want to look at, I mean, lymphoma is not to me, not a strong hypercoagulable state. We certainly see clots in those patients, but for some reason, these folks just focused in lymphoma.
All right. So in the next 15 minutes or so, I'll discuss a couple of things, unrelated topics, but I think they're interesting nonetheless. So this is a nice graph that I took from the FDA presentation at ASH about all the approvals in non-malignant hematology in the last year. I'm going to talk about three actually interesting approvals in the last couple months. One is recombinant ADAMTS13 for congenital TTP, both in children and adults, and then the 2 gene therapy products in sickle cell disease. So I'm going to start off with a presentation from Marie Scully, who's from the UK, and she presented her data on recombinant ADAMTS13, basically in patients that have congenital TTP and had acute events. So just as a reminder to everyone, congenital TTP is very, very rare, about an incidence rate of 1 in a million. So we think in the United States, there are about 300 patients with congenital TTP that have been recognized. We have 3 of them in our clinic. So we have 1% of the congenital TTP population. There's more than 200 causative mutations that have been identified. Oftentimes these patients present early in childhood. They have early strokes. Sometimes they can present in adulthood, especially in women with pregnancy as a major stressor and risk factor for TTP exacerbation. We have one patient who was identified much later in life, in his 80s with recurrent stroke. So it can have a disparate presentation sometimes. So the therapies for congenital TTP have not been fantastic. We've been using fresh frozen plasma mainly and cryoprecipitate. And there are these intermediate purity factor VIII products like CoA8 that contain ADAMTS13. But with the approval of recombinant ADAMTS13 in November, this results in much better control and much better levels of ADAMTS13. And I'm going to show some of the data that was presented. So this study that was presented at ASH was a phase 3 study, and basically was broken up into 3 main periods. They had patients that were randomized to recombinant ADAMTS13 and standard of care for the first 6 months, and they defined standard of care as fresh frozen plasma, or some of these detergent-treated plasmas like Octoplast, or these intermediate purity factor VIII von Willebrand products like CoA8. So those were what the patients were receiving, and in general, most of these patients were receiving them at steady periods about every other week. So they had a 6-month period where those patients were randomized in a 1-to-1 randomization. And then that was switched in period 2, and then period 3, everyone basically crossed over to receiving recombinant ADAMTS13. And in the extension phase of the trial, they continued them on recombinant ADAMTS13. So these studies are hard to evaluate because you basically have to wait for an event to occur in a patient. So they looked at 48 patients initially, and then they had basically 29 patients that rolled over in the extension phase of the trial. When someone had an acute TTP event and was treated with recombinant ADAMTS13, they used a dosing schema of giving 40 units on day 1, 20 on day 2, and then 15 international units per kg day 3 and onwards, until they basically had normalization of their hematologic parameters. And if you guys were on service with me a month ago, we were actually able to use this drug on a patient that had congenital TTP that presented with an acute stroke and had evidence of TTP exacerbation. And this is the schema that was approved by the FDA. They basically included all patients that had hereditary ADAMTS13, but excluded patients that had an inhibitor at screening. They define an acute TTP event as a drop in platelet count more than 50% from baseline and a platelet count that was less than 100, along with a twofold elevation in LDH. And then they created this category of subacute TTP, where the decrease in platelet count was not quite as severe, and the elevation in LDH was 1.5 times. So they basically treated 8 events of acute TTP. 3 of the events were treated on the arm that had the recombinant ADAMTS13. And then 5 of them were treated that occurred in the standard of care arm at the time. All of the events that were treated with recombinant ADAMTS13 resolved during that administration and didn't require any other treatments. Whereas one of the events that occurred in the standard of care arm occurred while the patient was receiving prophylaxis. And then they listed the types of potential triggers that they saw and their laboratory data in the patients that had exacerbations. So you could see a lot of them were due to infections. Some of them were even due to COVID. So it's clear that, you know, any potential infectious trigger is a big risk factor for developing an exacerbation of TTP. This is probably the most compelling part of the presentation. So as you can see in the dark red line, these are the patients that receive recombinant ADAMTS13 versus the blue line, which is the standard of care arm, which was fresh frozen plasma or treated plasma. The platelet counts were higher earlier in treatment, and then the ability to achieve higher levels of ADAMTS13 were much more attainable in patients that receive recombinant ADAMTS13 versus the standard of care arm. And we see this in our patients here. You know, patients that receive FFP or cryo can only elevate their ADAMTS13 activity by single digits, whereas our patient that we treated recently was able to achieve levels that were in the 80-90% activity range just with 1 dose. There were no serious treatment-related adverse events in the recombinant arm. You know, they reported some events like nausea, feeling hot, thrombocytosis, similar side effects in the standard of care. And importantly, they didn't observe any neutralizing antibodies against ADAMTS13 in the study. So in the 3 events that had acute TTP, recombinant ADAMTS13 was very effective and it resolved those episodes very promptly. You know, if you have patients that are acutely ill with a viral infection, it may be prudent in those patients to intervene earlier rather than wait for them to have an exacerbation and potential end organ damage. And then they didn't see any serious treatment-related adverse events or neutralizing autoantibodies. It's interesting that in the drug, because we are working on getting it approved in the outpatient setting for some of our patients, they do recommend having an EpiPen available, although they didn't report any episodes of anaphylaxis in any of the trials. So that was the section on recombinant ADAMTS13. There are studies ongoing looking at it in immune-mediated TTP, which I think would have a much bigger emphasis. There is a phase 2 study that was published in the last year looking at the use of recombinant ADAMTS13 after plasma exchange in patients with immune-mediated TTP. And I know UMIN is working on getting a TTP trial open here as well. I'm just going to move on in the next 5 minutes and discuss 2 of the gene therapies that were approved for sickle cell, and this happened concurrently with the presentations at ASH. So these are both very interesting gene therapy products, which are very hard to pronounce. So I think you need a degree just to pronounce these, but I'm going to use the brand name since they're easier to pronounce. Casgevy is the CRISPR product, and this is the first CRISPR product ever approved, but this is the one that's approved for sickle cell. And then Lyfgenia, which is the lentivirus vector that was also approved. The Casgevy is produced by a company called Vertex, and Lyfgenia is by Bluebird Bio. So Lyfgenia is basically a gene product that is infused in CD34 positive autologous stem cells, and it uses a lentivirus vector, and it contains a beta globin transgene sequence, the T87Q. And basically, these patients undergo stem cell mobilization with Plexifor, and then their hematopoietic stem cells are sent to the company where this transgene sequence is introduced, and then the patients undergo a myeloablative regimen, and then are engrafted, hopefully successfully, with these hematopoietic stem cells. So the basis for both of these products is basically a potent anti-sickling effect that occurs. So in patients that have hemoglobin S, their beta S globin interacts both in a lateral and axial contact in a tetramer formation, and that's what leads to the polymerization. In patients with elevated fetal hemoglobin, you don't have that lateral axial contact. So it's essentially an anti-sickling effect that occurs. And both of these gene products exploit that in different ways. So the Lyfgenia, which is the one that I just discussed, basically uses a mutated beta globin gene that has this T87Q mutation that doesn't allow the lateral contact to occur and doesn't allow the sickling polymerization to occur. So that's through its transgene. Whereas the Casgevy, which is the CRISPR product, this enhances, it disrupts an enhancer of a suppressor of fetal hemoglobin called BCL11A. And basically, this reduced expression of BCL11A results in de-repression of fetal hemoglobin. So you get an induction of fetal hemoglobin, and this ends up causing less polymerization to occur. The other thing to note is fetal hemoglobin also has a much higher affinity for oxygen than both hemoglobin A and hemoglobin S. So going back to the Lyfgenia product, which is the lentivirus vector, there have been a lot of studies. This one thing that you'll note between this product and the CRISPR product is there's a lot more long-term data that we have for the Lyfgenia product. So they've had a number of trials that have enrolled patients, anywhere from greater than 2 to 50 years of age. Also of note, when they initially did the studies in this for the lentivirus vector, they used bone marrow harvesting, and then later switched to stem cell mobilization in the Group C studies. So that was an interesting change that occurred. The data is pretty compelling regarding vaso-occlusive events. Basically, the solid line is when the patients underwent engraftment, and you could see that the number of vaso-occlusive events dropped significantly, by near 90% or so after the gene therapy product was engrafted. There were some, I think, safety events that are of note. Side effects related to myeloablation, like stomatitis, and obviously severe cytopenias occurred. 2 subjects developed AML and passed away. They don't attribute this to the transgene inducing any sort of oncogene, but this was an interest. These are obviously detrimental things to occur. One of the subjects went on to develop MDS, so it's not clear if it's related to the myeloablative regimen or patients that might have clonal hematopoiesis that are more predisposed to developing myeloid disorders. Also of note is stem cell mobilization and apheresis triggered sickle cell crises in 6 of these subjects, but there were no reports of any problems with engraftment. So Casgevy is the CRISPR product. So this is the other product that was approved. This is by a company called Vertex. And as I mentioned earlier, this disrupts the GATA1 transcription factor binding domain of the BCL11A gene enhancer, which is responsible for repression of fetal hemoglobin. So in a similar way, patients here have their stem cells mobilized with Plexa4 and then are sent over to the company. They undergo a myeloablative regimen with busulfan, and then the infused hematopoietic stem cells are then are infused into the patient. So CRISPR gene editing is very interesting, as some of you guys may know. It's a naturally occurring microbial defense system that basically introduces DNA breaks. These double-stranded DNA breaks occur when there's a base pair that's guided by a guide RNA near kind of the target gene. This allows pretty precise editing, at the genes that you want. But it can, if you have a sequence that's similar, you could potentially have off-target sites that occur, and this could lead to potential oncogenesis. So the trials are much less developed with Casgevy, but there's been basically 2 main trials, and they basically looked at patients that had sickle cell disease that had 2 or more events per year. And they defined events as either vaso-occlusive crises, priapism, splendic sequestration, or acute chest syndrome. The data with this is also very impressive. Basically, many of the patients, 29 out of the 31 patients, were able to achieve very long sustained periods without vaso-occlusive crises. They also were able to look at secondary outcomes like sustained fetal hemoglobin levels, and 30 of 31 had fetal hemoglobin levels of greater than 20% that were consistent for more than 12 months. So basically, as you guys know, the higher your fetal hemoglobin, the more phenotypically silent sickle cell disease is. So being able to sustain these levels is impressive and could essentially make the disease quiescent. Similar safety adverse events such as severe cytopenias and mucositis. Again, they saw a pretty high rate of sickle cell crises induced by mobilization and apheresis, so about a third of the patients, and no reports of graft failure. They didn't see any evidence of off-target genome editing, but that is a risk, and that's a black box warning that was added by the FDA. There are 2 big trials looking at the long-term effects of both of these gene therapy products that they're hoping to enroll patients from different centers and follow these patients for 15 years. And they'd like 250 patients on each arm, so we can learn more about the long-term consequences of these gene therapy products. So just a couple of differences that I wanted to point out. So, with the lentivirus vector, there is a risk of introducing a transgene next to an oncogene, where that risk is not quite as present with the CRISPR product. The advantage with the lentivirus, though, is that we have a lot more long-term data. So we've had 100 patients with sickle cell and thalassemia that have been that have been treated in the last 15 years with this or similar product. So we know a little bit more about this particular gene therapy and the potential long-term consequences. CRISPR is a little bit newer. There is still a possible risk of genotoxicity with CRISPR, especially if you have unintended off-target sites that are affected. And our experience is only limited to a couple of years with the CRISPR product. And then there are obviously acute and long-term toxicities with hematopoietic stem cell transplant and myeloablation related to those conditioning regimens. You still have to do, you really need to myeloablate the marrow for these regimens, because in order to engraft, you need about 20% of the affected stem cells to take. So, and these myeloablative regimens have their own risks, as you guys know. So, you know, we mentioned the risk of the risks in general related to that. There's also a risk of infertility that's important to point out. And then obviously, as I mentioned, the long-term follow-up that's needed for both of these products. I think this was the last slide I had. I know I'm over by a few minutes, but I'm happy to answer any questions.
Can I just make a comment about TTP?
Yeah.
So I think it's very clear that plasma exchange is going away in the next 10 years, right? So in my ideal world, in my perfect world, every hospital in the country would keep 1 dose of caplacizumab to give to a TTP patient, and cover them for 24 hours while the patient is being transferred to a tertiary center to receive recombinant ADAM-TS13, right? Because you can't keep a good supply of recombinant ADAM-TS13 in every hospital, but you know, Capla is really good at stopping thrombotic microangiopathy immediately, and it covers the patient for 24 hours while they're being transferred to a tertiary center. So that, I think, would be perfect. I don't know if the economics works out, and I don't know if Sanofi would like that, but that, I think, would be a great strategy, and it would be a lot easier in a nationalized healthcare system, right? But that's, yeah, just hopefully that's the future of TTP treatment.
Yeah, no, I agree. I think Capla is a great temporizer. That came up actually last month with a VA patient, where it would have been very helpful if they had Capla at the VA, for instance, before the patient got transferred. One thing I forgot to mention about recombinant ADAM-TS13 is you can get the product very quickly, within 6 hours, basically anywhere in the United States. And that was true. We were able to actually see if that happened, and it did. So the company's been good at doing that. I think there's still a lot of issues with, you know, getting the product approved in the outpatient setting for prophylaxis. But I think getting it inpatient, at least from what I saw a few weeks ago, it went pretty well, even on a weekend.
Okay, great. Thank you, Ibrahim and Matt and everyone just joined us.